Hello, my name is Carr. I'm with the World Health Organization in Geneva, Switzerland. It is my great honor to be able to present for the participants of the 24th ConRad conference today. The topic of my presentation is 5 C's of the mental health and psychosocial support in radiation emergencies. 5 C's are 5 cross-cutting issues which apply to the entire emergency cycle, and I'm happy to elaborate on this a bit further. But first of all, we should really remember what is actually mental health. I remind you that the classic definition of the WHO of health includes in scope mental health, but not everybody is familiar with the definition of mental health. And unfortunately, there is a certain stigma associated with this term. Sometimes people who are not professionals in mental health, they are reluctant to use this term. They're afraid that it's causing confusion and associated in people with some clinical diseases affecting mental health. However, this is not correct. We should always remember that mental health is a state of well-being in which every individual realizes his or her own potential and can cope with stressful situations, can work productively and fruitfully, and is able to make a contribution to the community. So this term mental health includes, in addition to the clinical diseases, of course, it includes also various emotional reactions and psychosocial reactions and effects. So when we say mental health, we do not mean necessarily diseased people, but people whose well-being is affected by certain factors. We should keep this in mind. We know that psychosocial impact of radiological nuclear accidents has been well documented in the past. We know that a number of high-level international standards and reports include and mention the arrangements for managing psychosocial impact of such emergencies. But we're still lacking a practical guidance on how this should be done in the setting relevant to nuclear emergencies. At the same time, we know that a massive amount of resources exists for managing mental health in general emergencies, but this has not been yet adopted for the nuclear emergencies. So what WHO has done, jointly with NEA, OECD, we started a project in 2018, within which the first part of it was to publish a framework for managing mental health and psychosocial support in radiological emergencies. We published this framework in November 2020. The webinar launching the network is recorded. You can see the link, or you can watch this webinar online. And you can download the framework document also in PDF from the second link. At the moment, we are in the second phase of the project, where the group of experts is developing derivative tools for practical arrangements in support for decision makers and emergency responders for efficient mitigation of psychosocial impact of radiological nuclear emergencies. The MHPSS framework structure is presented here, and you can see that the third chapter of the framework is focusing on 5 cross-cutting issues which apply through the entire emergency cycle: preparedness, response, and recovery. Let me talk about these 5 C's. The first C is coordination. Coordination is extremely important for efficient response for any types of emergencies. It's been stated as one of the key requirements in the international health regulations, also in the GSR Part 7 publication. The sectors most relevant for MHPSS would be health sector, social well-being, education sector, emergency response, and civil protection services, which will be involved in response. Typically, a working group will be established and led by health agency, and it will aim to include all complementary approaches used by other sectors for mitigation of mental health and psychosocial support. This group will elaborate a coordination plan, and it will build on available mapped resources and include following elements. It would be a roster of emergency response organizations which forms this group. It will have representation from wider systems, such as existing community support mechanisms, formal and informal structures, for example, schools, clubs, etc., general health services and general mental health services, social services, etc. Sorry, go back. Focal points will be responsible within relevant agencies in relevant administrative regions, and they will be having functional links for communication and established operation procedures. Task responsibilities, lines of communication should be defined, agreed, and should be clear to all involved partners. This will facilitate the development of integrated response plan. General health and mental health professionals should advocate and work in partnership with other sectors, for example, communication, education, community development, disaster coordination, law enforcement, etc., to ensure that relevant MHPSS interventions are timely and properly implemented. Second C is communication. Needless to say, public communication is one of the most important for mitigation psychosocial impact, and also one of the most challenging aspects of response. As we can see today in the response to global pandemic, there has been an extremely challenging and difficult period during especially the first year to manage rumors, misinformation, what we call today infodemic. Information is delivered by so many various media, and it's easy to be confused and easy to be anxious about something what is new, unknown, and dangerous. So similar to disease outbreaks and other emergencies, communication in radiological nuclear emergencies plays extremely important role. WHO has developed guidelines for communicating risk in public health emergencies. It's available from WHO website for download in PDF. Key components of public health emergencies communications aspects are building trust and engaging with communities of affected people, interacting between health and emergency systems in order to coordinate the communication, including governance, leadership, and coordination across sectors and stakeholders. Use strategic planning. In other words, to assess and evaluate the information on interventions in order to improve public awareness and influence behavior before, during, and after a public health emergency. We have a really good presentation delivered at the WHO session during the ERPA Congress in January, and the video recording of this session is available from this link. Third C is community engagement. The Generic Safety Guide 11, produced by IAEA and sponsored by WHO, defines community resilience as capacity of a community to be able to react quickly and easily from the consequences of a nuclear or radiological emergency. Sorry, to not react, to recover. Community resilience depends on various factors, each of which plays an important role. For example, local networks and relationships, leadership and governance, collective knowledge, health conditions, available resources, economic conditions, etc. In any crisis, the first point of contact will be immediate family, friends, colleagues, neighbors, or other next to kin. In most instances, communities will have some ways, such as systems, people, resources, to support one another in crisis. In other words, for example, local communities such as local religious institutions, activity groups, associations, societies, and other groups, they may have better understanding of local needs and are better positioned to respond in a more sensitive manner. Emergency planners should identify and map such community resources in advance. It is important to recognize, establish contact, and collaborate with people within this community resources prior to emergency and engage with them during the response and recovery following emergency. Emergency affected people are first and foremost to be viewed as active participants in improving individual and collective well-being, rather than passive recipients of services that are delivered by others. Using community-based MHPSS approaches facilitates families, groups, and communities to support and care for others in ways that encourage recovery and resilience. In addition, involving and engaging affected communities in decision-making through dialogues, through their active participation, also allows for them to share the ownership of the outcomes of the information products, of the interventions, and to reinforce trust in the authorities. Capacity building is the fourth extremely important component. We all know that without training in advance, the efficient response is not possible. So there are some recommendations for capacity building and resources available online. The last fifth C is core ethical principles. In general, core ethical values of MHPSS related work are similar to those underpinning the system of radiation protection. Beneficence, non-maleficence, prudence, justice, and dignity. Furthermore, when planning and implementing interventions, responders must consider the needs, best interests, and availability of resources of the affected population. Care must be taken that all those engaged in any aspect of community-based MHPSS are aware of the ethical values, of any abuse of these values, and maintain confidentiality. Services should be provided in such a way that vulnerable groups cannot be specifically identified by their vulnerabilities and stigmatized. There should be no racial, sexual, linguistic, or religious discrimination when providing MHPSS interventions to communities. Everyone should be supported, including indigenous people, migrants, minorities, people with disabilities, regardless of a person's gender orientation or identity. Responders should have capacity to respect local cultures, values, and to adopt their skills to suit local conditions. Here's the document which elaborates furthermore on ethical principles of MHPSS. To finalize my presentation, I would like to say that the mental health and psychosocial impacts of Fukushima emergencies were underlined by these very important reports. The ANSCI report, which was published on the 10th anniversary of Fukushima, and also the OECD report was published in March. In its recommendation area 7, it's stated that recovery from Fukushima, the Daiichi accident has involved not only physical health sciences, but also environmental, economic, social, philosophical, ethical, and emotional considerations. It is recommended that additional considerations be given to how to take into account the mental health and well-being of the affected populations. Such considerations will contribute more broadly to continued improvement in nuclear radiological accident preparedness and recovery management. This is a global challenge in which Japan has a unique opportunity to assume a leadership role. And this is a list of resources available on WHO website for supporting development of your interventions targeting mental health and psychosocial support. Thank you very much for your attention. Bye-bye.